Hello, I'm Kung Kyong Yeo. I'm a senior consultant cardiologist at the National Heart Centre Singapore. Welcome to this presentation, New Available Therapeutic Data in High-Risk Dyslipidemia. So let me start off by saying what we already know about lipid-lowering therapies in coronary artery disease, especially currently with the statin agents. In coronary artery disease, which form the bulk of the patients that I treat, the goal is to reduce myocardial infarction, myocardial events such as including cardiovascular mortality and death as a composite endpoint. Many of our patients whom we treat with statin therapy continue to have LDL levels that are still not optimally controlled. We know that the older guidelines recommend an LDL target of less than 100 milligrams per deciliter, and in high-risk patients such as those with diabetes, that we have that at less than 70. Of course, these guidelines have changed somewhat with time, and now the guidelines target based on the initial baseline LDL level. Be that as it may, for many of our patients, they remain suboptimally controlled. And we know that the lower the LDL levels are, the better our patients do. And we can reduce outcomes if we can get their LDL levels even lower. So we know that there is a need to reduce LDL levels. In literature from the PROVE-IT trial in which ezetimibe, let me rephrase that, we know from literature that if we use high-dose statins, the current generation of statins, whether it is atorvastatin at high dose or rosuvastatin, we can potentially reduce LDL significantly. And this does translate to cardiovascular outcomes, including myocardial infarction, repeat procedures, as well as other cardiovascular events, including stroke. We also know that the addition of other agents such as ezetimibe can also further reduce LDL levels. In the PROVE-IT study, LDL was reduced from 70 milligrams per deciliter to 54 milligrams per deciliter, controlling between the placebo and the treatment group. So this is a significant reduction, and this does translate to some degree of clinical improvement, with the primary efficacy endpoint being reduced by about 2% in absolute terms. So we have now these two major agents in our armamentarium. Largely the statins, and in patients who need it, ezetimibe. Other agents such as the fenofibrate have also been shown to help with lipid lowering from a lipid lowering perspective. But despite these agents, there is still a need, and some patients, despite being on optimal doses of statins, and even if you include ezetimibe, there are patients who remain suboptimally controlled. We are delighted that most recently at the American College of Cardiology meeting that the FOURIER trial showed results that demonstrated the value of a new class of agents, the PCSK9 inhibitors. In this case, the FOURIER trial studied evolocumab, which is a recombinant agent which targeted the PCSK9 target. And in this case, LDL was reduced across 27,000 patients by approximately 60%. Across a period of follow-up over 2.2 years, and this was also associated with an improvement in clinical outcomes, the main primary efficacy outcome being cumulative incidence of cardiovascular death, myocardial infarction, stroke, hospitalization for unstable angina, and or coronary revascularization. Now this, in my mind, is a very important study because it demonstrates reduction of LDL above and beyond adequate statin therapy, approximately 60% reduction in LDL with clinical improvement. Now the breakdown of the specific components of the primary endpoint showed that this was an associated reduction in myocardial infarction, stroke, and coronary revascularization in the treatment arm. There was no statistical significant difference in the rates of cardiovascular death or all-cause mortality, but we note that in other trials, such as the PROVE-IT trial, this was also not shown. I suspect this is largely due to the duration of follow-up and the fact that with very aggressive statin therapy, it is very hard to demonstrate any further reduction in mortality in the number of patients that we have in this particular study. Another monoclonal antibody that's been created to target the PCSK9 molecular target is bocozizumab. This is a different agent, and the studies were also released at the time of at the American College of Cardiology meeting in 2017. These were the SPIRE-1 and SPIRE-2 studies, and unfortunately, although there was some benefit, as you can see from the slides, in terms of LDL reduction in both SPIRE-1 and SPIRE-2, bocozizumab the results of LDL reduction was not able to persist with time. This is largely due to the fact that there is a murine, a mouse component to the antibody, and this is likely to provoke a immune response that weaken the efficacy of this drug. As I mentioned, SPIRE-1 and SPIRE-2, as you can see from this slide, for SPIRE-1 did not meet its pre-specified primary outcome. And although SPIRE-2 did meet its primary outcome, the combined data only showed a trend towards meeting its primary outcome. In addition, SPIRE-1 and SPIRE-2 did show some concerns regarding the adverse event rates. You can see here that the patients had some injection site reaction that was significant, 10.4% in the bocozizumab group compared to placebo, and there was essentially significant adverse reactions resulting in a drug discontinuation in the treatment arm. Now, the other drug that is being evaluated is the alirocumab agent. This has been studied in the Odyssey long-term trial, and we were glad to see that this particular drug also showed a significant reduction in LDL levels of approximately 60%. The subgroup analysis, remember that this trial was not powered to study the cardiovascular outcomes, but regardless, the subgroup analysis did show reduction in cardiovascular outcomes in a very small, in this cohort of 2,300 patients. We are awaiting the long-term results, the Odyssey outcome study, which hopefully will be presented soon, and this will tell us whether or not this other agent is also associated with improvements in clinical outcomes. So now that we know that there are these new agents, evolocumab, alirocumab, that are available hopefully in the near future for treatment of patients with high LDLs despite adequate statin therapy, what is our perspective on its use? What is its perspective on how we can treat these patients from my perspective, from an Asian perspective? I would say that the take-home message is that we now have drugs that can go beyond what statins can deliver. And the key is to find the right patients who will benefit from these drugs. So it doesn't change my perspective in what drugs I want to use at the beginning. At the beginning, I will start off with statin therapy and I will titrate as aggressively as I can to bring the LDL to goal, ideally less than 70 milligrams per deciliter. Now, in very high risk or in extreme risk patients, for example, as those described by the American Association of Clinical Endocrinologists, these patients are those who continue to have myocardial infarction or despite LDL levels at goal. In these patients, and such as those with poorly controlled diabetes, with kidney failure, stage 3, 4, 5 kidney failure. So in patients at very high risk or an extreme risk, that is such as those described by the American Association of Clinical Endocrinologists, these include patients who continue to have myocardial infarction or coronary events despite optimal LDL control, or those with very poorly controlled diabetes, advanced kidney failure. We would consider being more aggressive with LDL control. So in such patients, even if the LDL is less than 70, and if they continue to have events, I would consider putting them on this new class of drugs. Having said that, I think this has to be balanced against cost, and we will need to make sure that there are sufficient cost effectiveness study or value analysis studies to make sure that these patients are appropriately treated. So I'd like to summarize with the following points. Now, first of all, I think we have seen from numerous sets of data that LDL reduction is critical. It helps prevent coronary events, and that in practice, I still use the original guidelines in which we target an LDL of less than 70 for high-risk patients such as those with diabetes, and less than 100 for other less high-risk patients. This is despite the fact that I know that there are guidelines that now advocate a different strategy for targeting LDL. We know that despite adequate statin therapy, LDLs may not be adequately controlled, and therefore there is a role for a new class of agents that have since entered the market. The PCSK9 agents inhibitors do demonstrate a strong reduction in LDL levels. The Fourier trial demonstrated a significant reduction of cardiovascular events with evolocumab, and we are waiting to see whether the ongoing Odyssey outcome study will show us similar findings. I think in our Asian experience, patients at high cardiovascular risk should also consider the use of these agents if they remain inadequately treated despite optimal and high-dose statin therapy. Thank you for listening to this video presentation, and thank you for participating in this Medscape activity. Please continue to follow the other video presentations.